recording. But we have four amazing experts here, and what you've covered is like not only the oxygen targets, the fact that we have numerous different delivery devices, and then the timing of the interventions is important. I want to start with one big question, and I'll start with Chad, if that's okay, our colleague from the US. We've seen like a big buzzword in the COVID-19 strategy here has been high flow nasal cannula. Like everybody wants to use high flow nasal cannula, but high flow nasal cannula implies high flow rates. So Chad, can you talk a little bit about when does high flow nasal cannula make sense? What are some of the concerns with using high flow nasal cannula early, and any recommendations that you may have?
Yeah, absolutely. Thank you so much. I think just like Dr. Gupta and Vanilla were speaking of, really the goal is to match your therapy to what the patient needs. And so, as you mentioned, high flow nasal cannula, you're able to titrate up the flow, and that's how much liters per minute of air mixed with oxygen is getting to the patient, up to something like 60 liters per minute. In some patients, they may have minute ventilation requirements or be incredibly dyspneic and need those high flows. But I think one of the things that we've seen in many of our COVID patients is there can be quite profound hypoxemia without a lot of work with breathing, or their ventilatory requirements may not be that high. And so in those types of patients, they may not need those very high flows. They might need a higher FiO2 from the nasal cannula device, but not the high flows. It's also worth mentioning that the high flow will not provide a great deal. It provides a little, but not a great deal of positive end expiratory pressure. And so there's some thought, and now some randomized controlled trial data from the recovery trial, that non-invasive mechanical ventilation may be a preferred strategy in patients with COVID-19.
Thank you so much. And then, building on that, because I think there is a cost, right, to high flow with oxygen consumption. Dr. Gupta, as a head of your institute, the leader in the Department of Pulmonary Medicine, what strategies did the institution adopt to eliminate oxygen leaks, oxygen waste within the ICUs, within the high dependency units? Is there any strategies that you adopted that you could speak to? Dr. Gupta, you're muted. Thank you.
So maybe probably I can discuss some practical oxygen conserving strategies which we adopted, and then from ICU point of view, probably Vanilla can add on that. So the first thing which was very important, which we learned from the first wave, in the second wave, I would say, we set our targets a little lower, right? So the target oxygen saturations were set at lower this time, 92 to 94%. We have enough evidence to say that that is what is required for the good outcome for the patients. And of course, patients who are at risk of developing hypercapnic failure, for them the saturation was kept as 88 to 92%. Then also a kind of auditing is very important, plus policing, I would say, ensuring that the patients are wearing the masks properly. Most of the time, you may see that the mask is over the chin, or it is over the head, or when they are eating, they are putting it down. So we should always turn off the device, the oxygen, when the device is not in use. And when it is used, it should be properly kept to prevent, oxygen wastage. Again, prone positioning, awake prone positioning was something which did help in kind of patients requiring, they were better, plus their oxygen requirement did used to come down when they were in these prone positioning, awake prone positioning. Also, it was important then to look at the leaks at various levels, right? At the fittings, or at the supply chain, everything. It should be cautiously looked into it. So incorrect fitting or lack of adequate maintenance can give rise to all these things. Similarly, when we were using NIVs, our respiratory technicians, our ICU technicians were made to do rounds very oftenly to make sure that the leaks are not there in the mask, which may hamper with the oxygenation as well as, symptomatic deterioration of the patient can happen. So that was one thing. Then another thing which is important is using the correct oxygen delivery device for the amount of oxygen we want to deliver. So that is really, really important, as we saw in our, a case. So if you have to deliver oxygen, say up to 4 liters or maximum 6, nasal cannula is enough. If you go beyond that, say 5 to 8 liters, then probably you may need a simple Hudson mask. Beyond that, up to 15 liters or 10 to 15 liters, you may need a non-rebreather mask. And then, of course, venturi masks are certainly better, where you can actually decide how much amount of fraction of inspired oxygen you really wanted to give. Then Dr. Chad has already told about the HFNC. The other thing is, we were very cautious actually. Initially we did use, but then later we became really, really cautious about using HFNC, and we were trying to avoid wherever possible. So one thing is, in HFNC, we are giving a very high flow rate, and both inspiration and expiration, it is going the same flow, same volume of oxygen is going, which during expiration is really a wastage. So then there were some people, there were a study where they said that putting up a surgical mask over the HFNC would make some kind of a small reservoir, and may probably on a lower flows can correct the oxygenation of the patient. So that was one of the strategies. And we did, because in second wave, yes, thankfully by God's grace, we didn't had the problem with regards to oxygen shortage, but there was one particular night where we got a message from the director saying that we have oxygen only till tomorrow morning 6 a.m. and the admin was just running around, and by God's grace by morning 5 o'clock we had our tanks filled in, so we didn't face. But having said that, looking at the other part of the country where the oxygen was getting short, we did bought lots of concentrators, and then we used the concentrators for our patients who were requiring, lesser oxygen, say less than 10 liters or so. One thing we did kind of an oxygen auditing committee should be made, where probably a technician and the nurse can look into it. The potential leaks, a very simple thing is the flow meter which we have. So if you open up the cap of the flow meter has a small black, has a round black ring. Now, if that is missing, it causes excess leakage of the oxygen, which we may not know, but actually it is wastage of the oxygen. So, those are certain kind of the things. Some auditing committee should be there. We should look at all the leaks at all the places, and probably those were the things which we adopted. Vanilla, you would like to add on something what we adopted in our critical care setting?
I'll just spend a few seconds. So one thing which we did find just out of our for our patients was they didn't tolerate nasal high flow. In fact, most of the times when they reached ICU, nasal high flow just didn't work. They were just desaturating on it, probably because they needed more positive end expiratory pressure. And the usage of oxygen is definitely much higher with nasal high flow as compared to our NIV or invasive ventilation and the other devices which were available. So we consciously didn't use nasal high flow. So I think, I'm not going to repeat myself, but essentially I think the focus is on choosing the right device, choosing the right time, and optimizing your patients in all other ways possible. That helps in oxygen conservation. We did not use one ventilator for multiple patients because though that was proposed as a strategy earlier on, and because that the worry of infections and the worry of matching it with the patient's individual lungs, and also subsequently the guidelines which kind of came up saying that it's not a recommended practice. So that's not something which we did with the ventilators, though we did do that with some of the concentrators that could be shared between patients with a Y connector. So I'll stop here and then we can move on to some more questions.
Yeah, we're running a little short of time, but Binala, I want to ask you one question since you mentioned concentrators. So a lot of concentrators came into India at the start of the second surge. At your institution, where are those concentrators being used and who does it make sense to use them? And if we keep our answers short, that would be great.
So our oxygen concentrators were used in the ward settings, not in ICUs. Primarily because to connect an oxygen concentrator to a ventilator, you need a special type of ventilator with a low flow oxygen inlet, which is not available for many ventilators other than transport ventilators. So it is used in the ward settings. So we did buy, we didn't buy it, but there were lots of donations for oxygen concentrators. I think my suggestion would be that 10 liters oxygen concentrators are better than 5 liters because it can be used between patients with the help of a Y connector. A lot of mission hospitals, smaller hospitals across the country did use that. But the advantages of having a continuous oxygen supply is, the other side of it, other flip side of the coin is, what do you do with them after that? We've got 100 oxygen concentrators in the hospital right now, and they're not being used, and warranty is an issue. You need to have a team which is looking at it, making sure that the filters are changed, and so many things to look at. So yes, it did provide us with a good continuous source of oxygen supply, but there are cons to it as well. But we'll probably be distributing it to the other smaller hospitals across the country now, I guess.
And I'm going to stop.